Very much. I'd like to first of all thank the moderators here for inviting me to give this presentation. I'd also like to thank Dr. Ballesteros and Dr. Soto for inviting me here, as well as the Mexican Association of Hepatology. This is my first time in Mexico, and I enjoy myself despite the rain. So I'm very happy. Thank you very much. So what I've been charged with, and they've given me 30 minutes, what I've been charged with is to talk about gastric varices treatment, Glu BRTO, and embolization or TIPS. So it's also going to be difficult, I think, following Dr. Garcia Sao in her lecture and also Dr. Contreras in his lecture, but I'll try my best. So what I would like to say is I'm going to be presenting a management of bleeding gastric varices. It's a recent 2018 Audiovisual Award winner at Digestive Disease Week in Washington, D.C. just a few weeks ago for the American Society for Gastrointestinal Endoscopy. So what I'm going to present is an adapted version of the Audiovisual Award presentation that we had. And it's going to be with my colleagues here, Drs. Davikov, Keeper-Emmons, Eisenberg, Patel, and myself. So let's start with this. So basically, what we all worry about is when we see this kind of patient, it does increase your heart rate and increase your blood pressure. Although the patient's heart rate and blood pressure, the heart rate's going up, but the blood pressure is going down. So that is a problem. And let me see here. Oh. Is the slide on? Whoop. Here we go. It's so good. I think it's showing you again. Anyway, but this is what we're all worried about. And gastric varices can be seen, as you know, on inspection during upper endoscopy. Can also be seen. They can be various shapes and sizes. The bigger ones are the worst. They can be seen often on imaging studies. The gastric varices here, you can see a splenorenal shunt as well. Gastric varices are present in about 20% of patients with cirrhosis, and the GOV1s, the ones that come down the lesser curve, makes up about 75% of all gastric varices, and the isolated gastric varices mainly occur with segmental sinestral portal hypertension, also known as left-sided portal hypertension. The isolated gastric varices, it's important to know that they're also seen in the setting of splenic vein thrombosis or stenosis. So this is very important for us to exclude, because if a patient has isolated gastric varices from splenic vein thrombosis, the treatment is not reduction of portal pressure, it's actually splenectomy. So that's important for us to remember as clinicians. So we all know about the classification of gastric varices. This is from Sarin, and you can see here he divides it into GOV1, GOV2, and the isolated ones, the IGV1 and the IGV2s. All right, so we know about that. In terms of bleeding risk, we know that the highest bleeding risk is in the IGV1s, more so than the GOV2s, and then comes the GOV1s and the IGV2s. We also know that large size of the varices, red color signs, and severity of liver dysfunction also makes the bleeding risk worse. In terms of general management of gastric varices, the initial management is the same as esophageal varices. In other words, we have to resuscitate the patient, use a restrictive blood transfusion policy, vasoactive infusion, and antibiotic prophylaxis. We can use temporizing measures. So in other words, we could use variceal band ligation, sclerotherapy. We could use gastric balloon tamponade. So when you see a patient like this in the middle of the night, very few things work except for a balloon tamponade. So balloon tamponade is what we used in this patient. Even the new hemospray that we have would not really stop this bleeding. So this patient required a balloon tamponade. For 24 hours, the patient went for emergency TIPS and actually did well and left the hospital. In terms of definitive treatment of gastric varices, I'm going to talk about some band ligation for the GOV1s, cyanocrilato glue injection, and interventional radiology, such as BRTO, CRTO, and TIPS. In terms of surgery, spoke earlier about the isolated gastric varices secondary to splenic vein thrombosis or stenosis. These patients need to be evaluated and sent to surgery for splenectomy or for angiographic embolization of the spleen by interventional radiology. Liver transplantation can also be considered. I'm going to focus on glue injection and the techniques of BRTO, CRTO, and TIPS. In terms of choice of treatments, this actually is from the Hepatology Guidelines by Dr. Garcia-Sao et al., published in 2017. And as we mentioned again, it's important to exclude splenic vein thrombosis and isolated gastric varices. We talked about that. Let's talk about glue injection. Glue injection, the confusing thing about glue injection is that there's many ways to do it, and that's what makes it confusing. And the ways that do it, they vary in complexity and cost. But it does make it confusing for the gastroenterologist and for the hepatologist. So glue injection was actually first reported a long time ago in 1986 by Nib Sahendra in Germany, published in Endoscopy. So we know that from many studies that glue appears to be effective at stopping acute bleeding with significantly low rates of recurrent bleeding in the long term. That has been shown. These are the practice guidelines I talked about by Dr. Garcia-Sao and her colleagues. And I'm just going to read two sentences from those guidelines. So these guidelines say that cyanoacrylate glue injection is an option for cases in which TIPS is not technically feasible, but it is not FDA approved in the United States for treatment of gastric varices and should be performed only in centers where the expertise is available. In centers with expertise in cyanoacrylate injection, it would be reasonable to reserve TIPS for failures of medical plus endoscopic glue therapy. So these were the latest guidelines state in 2016. So what are the contraindications? I think for anybody to start doing glue injection, it's important to know what the contraindications are before you start doing this. And obviously one of them is lack of glue expertise, allergy to glue, allergy to formaldehyde. That's actually important. It's not something that we routinely ask patients during a history and physical, but some of these glues do contain formaldehyde. Allergy to some of these contrast media if used like lipoidal, etheridol, or iodine. And extra caution in patients with known large gastrorenal or splenorenal shunts, known cardiac septal defects, and known hepatopulmonary syndrome. I'm going to go through a technique that we've been using in Cleveland at Case Western Reserve University at my hospital for the last 3 years. And this is actually a simple technique. It's non-EUS, but this is what we've been doing, and it's quite effective. In the US, as opposed to here, glue is not FDA approved, so we do need a special consent form. The technique that we have does not use EUS, but it uses a diagnostic gastroscope, uses large injection catheters, and we also use the N-butyl 2-cyanoacrylate, which is histoacryl, or it's the 4-carbon form of the cyanoacrylate. And I'll talk about that more a little bit. We use it neat, in other words, it's not diluted. We also use sterile water for injection, and we flush the biopsy channel of the endoscope with olive oil to decrease the risk of glue sticking onto the endoscope, which would be bad. We use eye protection for the endoscopist, assistants, and for the patient. And we also, this is optional, we also use a non-EUS through the scope Doppler ultrasound probe. It's a single-use probe that we use, and we think it really helps. So what we do is we do an initial upper endoscopy to identify the culprit bleeding varix as a source of bleeding, with a plan to treat the bleeding varix during the index endoscopy. We demonstrate typical venous flow pattern by using the Doppler probe. We prepare the field with the recommended items. However, you should wait until the last minute to drop the glue because it does polymerize quickly. We start by flushing the 10 to 15 mLs of olive oil through the accessory channel of the endoscope. We then prime the injection needle with sterile water. We decide on the volume of glue injectate based on the size of the bleeding varix. And this is a rough gauge, but what we do is if it's a small varix, we inject 0.5 mLs of neat histoacryl. If it's medium size, we inject 1 ml, and if it's large, we inject 2 mLs. Once the volume is decided, we puncture the varix with the needle and inject the glue by rapid bolus. That's important because these glues polymerize very quickly, especially the 4-carbon, 5-butyl cianoacrylate. After injection of the glue, we quickly flush the needle with sterile water, and then in terms of the volume of sterile water, it's actually the dead space of the needle plus half an ml. We retract the needle, we don't keep it in there, and we pull the needle out. And we expect some immediate back bleeding. This is actually good. We actually like back bleeding because it means you're actually in the varix and you're not submucosal or anywhere else. The back bleeding should be self-limited, so don't get worried when it bleeds. We wait 2 minutes and then we determine whether the varix is thrombosed, all right? And you can do that in 2 ways. You can either do it the traditional way, which is you probe the varix with the tip of a blunt needle to see whether it's soft versus hard. I would argue that that way is very subjective. It's what's soft to one person and what's hard to another is also very different. And there could be different variations like cheeses, like semi-soft and semi-hard and firm and whatnot. I mean, who knows, you know? And how hard do you press? I mean, please, we never know. But anyway, so what we try and make it more objective by using a through-the-scope Doppler ultrasound probe, which is a very simple probe that we pass down the biopsy channel of an endoscope. And we basically look for active venous flow or diminished or absent blood flow. If the varix is still very soft, or if there's still strongly active venous blood flow by Doppler probe, we consider injecting additional glue in an adjacent site. What we found is that the maximum aggregate glue injection per varix is 3 ml, so we don't inject more than that. The other thing we do is in the first upper endoscopy with glue injection, we only treat the culprit bleeding varix, okay? We don't treat everything. We only treat the one that's bleeding. And we know it's the one that's bleeding because it's the one that's spurting, or it has a white nipple sign, or has red spots or something, you know, something to tell you that's the one that's bleeding. We just treat that one. On the other hand, at the follow-up EGDs, then we treat the other medium to large gastric varices with glue injection. This is at the follow-up EGDs. And can we run this video, please? And this is a glue injection of bleeding gastric varices the way that we use it. And I think is the audio up as well? That's what venous blood flow sounds like. That's the Doppler probe. That's what venous blood flow sounds like. That's what we're listening for. Now we're injecting cianoacrylate, as I said, undiluted, neat, into the varix. And then we actually use the Doppler probe again and to see whether the blood flow has gone or not. And this really helps us, I think, to titrate the volume of blood, of injectate, of glue. You can hear there the Doppler ultrasound signal is now absent, indicative of hemostasis. So then we stop. And I think this really does help us to titrate the volume of glue. We want to inject the minimum effective volume. So let me repeat that. We want to inject the minimum effective volume. Injecting too much glue can lead to systemic embolization, which is we all worry about in terms of causing strokes and pulmonary embolus and etc. So we inject the minimum effective volume by using this. And in terms of other methods, now let me talk about some other methods here. The freehand glue injection technique without the Doppler probe and without EOS is the most widely used technique worldwide by far, all right? This is just using a straight gastroscope without EOS and without Doppler probe. Does not require advanced endoscopic skills. The one that we've been using is the freehand glue injection technique with the Doppler probe. Does not require advanced endoscopic expertise and does not significantly add to the overall cost. The cost of the probe is about the cost of a single clip. In terms of EOS-guided coil and glue embolization technique, this has been quite topical in the last few years. But the problem with this technique is that it is limited to centers with advanced EOS expertise. In fact, not every endosonographer is able to inject coils, so you have to find the select few of endosonographers. So you have gastroenterologists, hepatologists, you have endosonographers, which is like this, and then you have the ones able to inject coil, which is like this. So you're really narrowing the pie. So it's very limited to advanced EOS expertise, and plus you have the additional cost of the coils and the EOS. Post-glue injection, continue IV ectratine infusion for 2 to 5 days, then initiate non-selective beta blockers, continue standard dose once daily PPI. At the first surveillance EGD, we do it at 1 week. and we inject or don't inject glue based on the Doppler probe signal. And then every 2 to 4 weeks until the culprit gastric varix has been thrombosed. And at the follow-up EGD, we also treat other medium to large gastric varices, but we don't treat the small gastric varices. A program of surveillance EGD is required to detect gastric variceal recurrence. Esophageal varices, it's important to note that esophageal varices can increase in size following glue injection of gastric varices and may require band ligation to treat the esophageal varices. It's also important to know that a glue cast forms at the site of the glue injection, and the glue cast will eventually be extruded into the stomach and pass through the GI tract. It can expose a scar and an ulcer that can sometimes bleed, but usually the bleeding is mild. Refractory gastric varices, in our protocol, we send for TIPS or BRTO. So this is what a glue cast looks like. You can see here, this is what it looks like. This is the initial glue cast. This takes several weeks to months. This is what it looks like. This is the evolution of it. That's when the glue cast comes out, and it forms this ulcer, which can bleed. It usually is a mild bleeding. If you follow it for a few more months, it heals, and then the scars, and then there's a little scar, and it's gone. Okay, so this occurs over many weeks to months. Risk of systemic glue embolization. Well, that's actually very important because we all worry about that. There are in the venous system, there's risk in patients with gastrorenal and splenorenal shunts, causing pulmonary embolism, splenic vein and portal vein thrombosis, and septic emboli. There's also arterial glue embolization that is at risk in patients with patent foramen ovale or hepatopulmonary syndrome with AV pulmonary shunts. Strokes, multi-organ embolization, and septic emboli can occur. It is also important to understand the different polymerization rates of glue and how they're affected by the type of glue, by the additives, and by the technique of glue injection, okay? One thing that's important to take note is that not all glues are the same, and this is very, very important, all right? Not all glues are the same. This work was really pioneered by Stephen Caldwell from University of Virginia. This is an article from him in American Journal of Gastroenterology in 2012. We know that glues are 4-carbon, which is the N-butyl 2-cyanoacrylate, which is histoacryl, but many people use the 8-carbon, which is Dermabond, that's the brand name, which is a 2-octyl cyanoacrylate. We know that the 4-carbon group has much faster polymerization than the 8-carbon, so that's important to know, all right? Because theoretically, faster glue polymerization may theoretically reduce the risk of systemic embolization, okay? You want the glue to glue right there and then in the varix. You don't want it to stay around because then it has time to travel around the systemic circulation. It's also important to know that the addition of contrast media such as lipoidal or ethiodol significantly slows down polymerization, significantly, all right? So that's important. That's why we use it undiluted. What are the complication rates? Well, in the US experience, this is a retrospective single academic major center in the United States. This is their experience. They had 95 patients treated for gastric variceal hemorrhage with glue injection. They used a freehand glue injection technique without a Doppler probe or EOS, using the 8-carbon 2-octyl cyanoacrylate undiluted. Their mean glue injectate was 6.5 mLs per session. Vascular and cardiac anatomy were not predefined before glue injection. And the aim of that study was, or that paper, was for complete variceal obliteration in a single session with multiple 1 to 4 variceal sites injected. The complication rates, there are 95 patients. The initial control of bleeding was very successful, 100%. Successful or durable hemostasis of more than a month was in 92%, and failed hemostasis with recurrent bleeding was in 8% of patients. Serious glue-related adverse events was in 2 patients. Both had pulmonary embolism. One was fatal in the failed GVO group, and on autopsy revealed embolic glue emboli in both lungs. The all-cause hospital mortality in this patient was 12 patients, hemorrhagic shock, renal failure, metastatic HCC, hemorrhagic stroke, and the pulmonary glue embolism. Now, this is a big study from China, a retrospective study from 2 academic centers in China. They had a total of 753 patients treated for gastric variceal hemorrhage with glue injection. freehand technique without the Doppler probe or EOS, using the N-butyl 2-saccharylate plus lipoidal 1-to-1 dilution. Now, note that the mean glue injected here is much lower, 1.4 mLs and 3.3 mLs, okay, much lower than the previous 6.5 mLs, all right? Again, vascular and cardiac anatomy was not predefined. In this study, only 5 patients experienced systemic embolization. None of them were fatal, all right? So this is a big study, retrospective, and quite different from the results that we had before. Let me shift gears a little bit to talk about BRTO and CRTO. So this is, in terms of BRTO and CRTO, you need venous access. You need to define the anatomy of the varix and the vessels around it. This is a venogram. You can see here where a patient had a gastric balloon in because it was one of those patients that was really, you couldn't stop. Through a either femoral access or a jugular access, we inject the radiologist, this is interventional radiology, is injecting contrast to define the gastric varicose system, define a portal venous system. And then once defined, this is where the balloon occlusion occurs in BRTO. This is BRTO, all right? Where they occlude they define the gastric varix, they occlude the vessel, and they inject sclerosant. And the sclerosant there lies for about 30 minutes to several hours. That's called dwell time, okay? So they do this over several hours. These are the gastric varices, and a different technique is CRTO, where instead of using the sclerosant, they inject coils, okay? But similar method, they inject coils to plug up the varix, all right? And where they can abolish the gastric varices and also the splenorenal shunts. Obviously, you have to have very good interventional radiologists to do that. In terms of a quick meta-analysis, this meta-analysis had over 1,000 patients with acutely bleeding or at-risk gastric varices treated with BRTO. The technical success rate was 96%. The clinical success rate, i.e. no recurrence of rebleed, was 97%. Major complication rate was low at 2.6%. However, you got to know that when you do BRTO, you do increase the portal pressure, and esophageal varices do increase in size, and the recurrence rate in this study was up to 1/3 of esophageal varices. In terms of TIPS, TIPS is the most widely used procedure to treat gastric variceal hemorrhage with more than 90% success rate. We have absolute contraindications and relative contraindications. I'm not going to go through them, but I think we are all aware of these. In terms of choice of treatments, in the US, TIPS is frequently used as the first line of treatment. Common endoscopic therapy such as band ligation and sclerotherapy is effective at stopping bleeding in the immediate short term, but the risk of recurrent bleeding is high. So you don't want to do this because the risk of recurrent bleeding is high. So in the US though, glue injection is not approved by the FDA for intravascular injection and must be used off-label, but in the rest of the world, we can use it for glue injection. In the US though, few endoscopists know how to use glue for treating bleeding varices, and there's concern about systemic glue embolization. In terms of pros and cons for glue injection, in terms of the pro or the advantages, glue injection is superior to band ligation and sclerotherapy. It is minimally invasive and inexpensive and can be performed in acute hemorrhage. The con is that in the US at least, it's not FDA approved. There's risk of systemic embolization and endoscopic surveillance is required. In terms of TIPS, TIPS is widely available in the United States. Endoscopic surveillance is not required and can be performed in acute hemorrhage. The contraindications of TIPS, in some of these patients, they often, with cirrhosis, they often have severe CHF or severe hepatic encephalopathy, all right? In those patients, it is contraindicated to put in a TIPS. It is more invasive than endoscopic therapy and it is expensive. In terms of BRTO and CRTO, the pro side of this is that BRTO, CRTO can be used in the treatment of gastric variceal hemorrhage, not due to portal hypertension, all right? The difficulty is that it cannot be used in the acute setting because the dwell time for the sclerosant is at least 30 minutes and usually 2 hours, all right? So in somebody who's exsanguinating, you can't leave them on the table for 2 hours, okay? So it's a long procedure in terms of duration and so cannot be used in the acute setting. It also may increase the risk of esophageal varices and ascites, It's more invasive than endoscopic therapy, expensive, and not widely available in the US. In conclusion, in medical centers with no specific expertise available, it is recommended to institute temporizing measures and transfer a patient to a tertiary care referral center. At a tertiary care referral center, TIPS still remains the most widely used treatment for bleeding gastric varices in the United States. However, in centers with glue expertise, it is reasonable to start with glue injection first and reserve TIPS for glue failures, but recognize that glue is not FDA approved in the US for this purpose. Importantly, a glue is less expensive and less invasive than endovascular treatments and can be done in settings of acute hemorrhage. BRTO is another option, but requires specific local expertise and requires several hours to complete and therefore cannot be used in the acute setting. And lastly, some interventional radiologists have advocated a combination of BRTO and TIPS, may be an option, but adds extra time and cost to the overall procedure. So thank you once again for allowing me to give this talk to you. We're all trying to treat these patients with what you see here. Thank you very much. Thank you for your attention.